about the session today and the topic that we have. It's based on a study that our study team has developed and is currently in data analysis with. So we're going to talk about some of the emerging things that are coming out of this, but it really is this idea about, what are family counselors doing who are working with family members of folks that have substance use disorders? How much time are they spending and how comfortable do they feel with discussing neurobiological concepts of addiction with the family members? We know a lot of that goes on in treatment. We'll talk more about that in just a bit. But I'll take us through our agenda real quick. So really, the things that we want to get accomplished today is to look at the introduction and look at the rationale for why we decided to do this study, a little bit about what we found from our literature review, and then talk about sort of how we approached putting this together. It actually ended up being fairly difficult for us to be able to find the participants, and I'll talk more about that later about why it's difficult to identify family counselors that are doing this work. And then to get the response, but we did get the response that we needed. So Dr. Warren will talk a little bit about the methodology and the initial analysis of that data, and we'll hopefully end up on the back end of the session with talking about where we think we're going with this and what it all might mean. So yeah, I think I wanted to start with talking about sort of where I came from with the idea for the study, why I'm excited about. I see a lot of some of my former students and current students in the session, and I really appreciate that. And they probably were going to roll their eyes a little bit when I start getting really passionate about talking about the neurobiology of addiction. I teach a course here at App State on the neurobiology of addiction, and I've been in the addictions field for, from the very beginning of my career. So over 20 years where I've been working with folks that have, substance use disorders. And one of the things that I learned as I went through my career, in the early part of my career, I was really sort of grasping on to working with the modalities that were popular at the time, CBT and 12-step. And over the span of my career, I've really started to look at some things that were going to help us kind of move past some of the, kind of dismal clinical outcomes that we have for people who are getting treated for addictive disorders. I mean, the numbers aren't great, and we'll look at some of those stats in just a bit too. And made me really think about what is it that we're missing sort of in the treatment process with the clients. And part of that was that I feel like we ended up not really talking with clients enough about addiction being a brain disorder that is neurobiologically motivated. For sure. Can we go back once to the previous slide, Damaris? I just want to talk about that idea for a minute. So this idea that addiction is neurobiologically motivated. There's a book, if you really want to get into the nitty gritty of what is going on in the brain of people with addictions, I want to give you a book recommendation. It's from Dr. Judith Grisel. And it's called Never Enough: The Neuroscience and Experience of Addiction. I use this book in my class for the Neurobiology of Addiction course, and I recommend it to anybody that is interested in that. And what's unique about this book and about the concepts that she brings to the book that I think need to be communicated not only to the clients but to their family members is this idea that addiction is really genetically and neurobiologically motivated, like I said. And so that there's some predetermination, predisposition to this, and that there are some people based on their brain chemistry that are vulnerable to becoming addicted to chemicals and to other process behaviors too. And there are some folks that are not. And she gets into, she gets into the chemistry of that. She gets into the neurobiology of that in the book in a way that's really accessible. But I think what's really valuable about this book is that Dr. Grisel came to be a really respected neuroscientist from the recovery of, she was in recovery from her own addictions. I mean, her story is wild. So if you want to hear, she talks about that in the early part of the book. And one of the quotes that comes out of the book that really just resonates with me, and that I use a lot in my own teaching and presentations, is this quote. And she's talking about her recovery. She's talking about 20 years later, after 20 years in recovery, after having gone through like hell. For her, it was hell. She almost died multiple times. She had multiple addictions to multiple different substances. She was able to get into treatment, into recovery. And 20 years later, she's got a PhD in neuroscience. She's on, the Today Show, and she's on all of these big TV shows talking about this book. And she says this in the book. She goes, as far back as I can remember, I felt hemmed in, frustrated by imposed limits and my own limitations. Longing for other or for something else is at the core of my experience of self. Even today, below the persona of nurturing friend, committed partner, determined scientist, and adoring parent is a heartbreaking desire to embrace oblivion. That is like one of the most powerful quotes that I've seen in any types of memoirs or books or about addiction. And what it says to me is that this really emphasizes how rooted neurobiology is into understanding addiction, right? So let's talk a little bit about that, about what neurobiology is, or what addiction is. And how it's connected to the neurobiology. So addiction's a chronic, progressive, and treatable brain disorder. I think we maybe hopefully all agree that that's true. The changes that happen in the brain as the result of the use is really the second phase of what is creating the addictive process. The first phase is really genetic in nature. There's things that, there's lots of arguments, debates in the field about whether someone is sort of born with an addiction or do they develop an addiction. And I think the answer probably is that it's possible to be both, but that people can be born with vulnerabilities, genetic predisposed vulnerabilities that make them more vulnerable to addiction. And so that what they're basically waiting on through that early part of their life is just an encounter with drugs and alcohol. And once they have that encounter, the drugs and alcohol correct the dysregulations of the brain that are there and really create this sense of satisfaction and contentment. It reduces the restlessness that is often felt in people that have this sort of brain wiring. And that they're like, wow, I found something that works. And so they go back to that and they start to create this addictive process when they start to use in a regular pattern. The real evil of addiction is that there's already a dysregulation probably before anyone ever uses drugs and alcohol. Then they find the drugs and alcohol, it sort of corrects it temporarily. But then after you get into active addiction, that the drugs and alcohol create an even greater, more profound dysregulation of the drugs and alcohol. So then you end up at a worse end. And then what happens is that at some point, we hope that that person gets into treatment, and there's going to be all kinds of things that are going to be happening with that. There's treatment, there's all kinds of post-acute withdrawal problems, there's all kinds of issues related to that. But one of the things that we know that really works is that people have a much more of a chance at success in treatment if they have a supportive network around them. So if families and friends and the people that are in the person's life that has the substance use disorder are educated and understand that this isn't just about this person being selfish or having a lack of willpower or being powerless or any of these other things, if they understand that this is a brain disorder that is creating really complex, problematic processes in the brain that create this behavior change, then there's a real possibility then that the empathy can really be more profound for the family members, that they can say, okay, I understand this for what it is now. I know what I'm dealing with now. And I think that's really important. So this neurobiology is really important. So genetics, as we think and move forward in the slide, that this idea of this genetics is that 50 to 75% of the likelihood that a person will develop addiction comes from genetics. So that is that really strong predetermination that if this is present genetically, that it's very possible that folks are going to develop it if they decide to start using drugs and alcohol. And, it's a complex kind of genetic picture to take a look at, because there's not one gene that we can just identify that says this is what causes addiction. It's what we're seeing in the research is that it's a complex combination of genes and things that are happening. But what we also know is that these genetic vulnerabilities create vulnerabilities in other areas too. 50% of folks with substance use issues are also going to have, some kind of other comorbid disorder. So one of the things that we really want to just kind of pay attention to is that this is there and that runs in families, and that's part of the education that we can do with families is to say, look, this is something similar to diabetes or heart disease or some of the other medical disorders that have some of those same types of genetic predispositions. Now, neurobiologically, and as we look at what's happening from the brain standpoint of things and what creates addiction in the brain, it's the mesolimbic dopamine system, essentially. All drugs of abuse are working with dopamine. And what we believe, and this is important, and then we're going to start moving into talking about sort of our study and what we're wanting to try to do, but this is important. So if we understand that dopamine is the neurotransmitter that's implicated in addiction most prominently, and we also understand that genetic predisposition that we've been talking about has to do with that most likely people that are genetically predisposed to addiction have less dopamine receptor sites or less sensitive dopamine receptor sites. If we can understand that, then we understand the stories that our clients tell us. I'll tell you that I've treated hundreds of people for addiction, and the story that I've heard hundreds of times from people with addiction is that they believe that from very beginning that they felt different than, that they felt less than, that they felt on the outside of, and they could never really put their finger on what that was. And I believe that is because that they had their brain wasn't able to process and receive dopamine in the same way that other people who didn't have that dysregulation could. And what that meant was that they were not really able to feel the full spectrum of joy and contentment. And so that is, that leaves, them having experiences and everyone else having these profound experiences, but them just kind of going, it was okay. And then they find, themselves in some place where they are offered some type of drug or alcohol. And drugs and alcohol, by the way, are very efficient and effective at releasing dopamine into the synapse. And so they have these dopamine rushes and they have this euphoric feeling. And for people with addiction, with this type of genetic addiction, it is not about feeling good. It's about feeling content and satisfied and normal, right? And that feeling is really, really attractive. And so people go back and start doing that. So I think that is like, what if everyone around the person that had the addiction understood that, understood this process, understood that? I mean, we did it, we went through it very quickly because we have limited time. But what if people around the person with the addiction understood that for what it was? And how would that change their reactions to their loved one, and how would they differently support them? So I wanted to start talking about a little bit about the study and really thinking about why we're interested in that and some of the initial findings that we have. I'm going to turn it over to Damaris. Damaris is a doc student at NC State, but also came from her master's program here at App State, and she's on our study team, and we're excited to have her. And so she's going to talk a little bit about, along with Jessie Butler, I should say, who is also an alum of our program and is now out working. Jessie couldn't be with us today because she is a clinician in a VA system that is not going to allow her to take any time off to do the conference today because there's too many clients to be seen. And so we appreciate that. that she's out there doing that work, but she did record some things. So I'm going to turn it over to Damaris to talk sort of about the prevalence and some of the lit review piece to this study.
Okay, great. Thank you, Dr. Schwarze. Again, my name's Damaris, personal pronouns she, they, them, and I'm a first-year doctoral student at North Carolina State University, so back in the Raleigh community, which I'm very happy and grateful for. So getting started, I think it's important to address the prevalence of addiction. So how widespread are substance use, misuse, and substance use disorders in the United States? So we see that there's over 175 million persons aged 12 and older reported alcohol use in the past year. We also have more than 36 million reported using marijuana in the past year, 12.5 million reported misusing prescription pain relievers, and over 300,000 reported using heroin in the past year. So almost 8% of the population met diagnostic criteria for substance use disorder for alcohol or illicit drugs, and other 1% met diagnostic criteria for both an alcohol and illicit drug use. So although we see here on the slide that 21 million people met the diagnostic criteria for substance use disorder in 2015, only 2.2 million individuals received any type of treatment. Of those treated, 63.7% received treatment in specialty substance use disorder treatment programs. In the first year, I think this is really important to highlight, especially when you're working with clients who are coming in struggling with addiction and also struggling in recovery as well as their first year of recovery. The data shows that there is 40 to 60% will return to active substance use. So a relapse may happen. So thinking about having those conversations with your clients so that support system is getting built in. So I'm going to transfer this over to Jessie, and as Dr. Schwarze says, she cannot make it here with us today. However, we do have a video recording of her speaking on her part on the literature review. And if you all can just give me a thumbs up so I know that the audio is clear on your end, that would be helpful for me. It used to play. Well, I guess it's not playing. I don't know what happened. I don't know if that's a. Nope, it's playing.
So here, although we list the basic.
Let me try again. Dr. Schwarze, are you able to?
Here it is.
So here, although we list the basic definition of addiction, the effect of addiction on the individual is anything but basic. It is all encompassing of the individual, and it affects different levels of their life. Yes, the physical, the mental, emotional well-being, sure, but it also affects the intersection of other aspects of their life. This is all rooted in this neurobiological predisposition for this disease. This effect moves beyond the individual, it moves beyond the single person and into their environment and their relationship with other people. These are their family members and their loved ones and other social support systems. So in this present study and from this research team's perspective, we see the need to then bridge the gap to teach those who are affected by their own addiction plus the family member who was also affected in the active addiction process about the neurobiological root of this condition in order to ultimately fully treat the individual to then embark on the process of recovery and healing from this disease.
Okay, perfect. So we're going to talk about families and substance use disorders, and then we'll move into need and treatment. So there is at least 25% of US families have a loved one with an SUD, and 90% of those with SUDs live in the home with their families or significant others. So along with what's given in the data, the takeaways to understand the effects of substance use disorder or addiction are felt by the entire family. It's a whole family that is feeling it. Making it paramount that battling addiction is viewed by many as a personal experience because harmful substances having devastating effects on the user. Many may not take into consideration the other people involved. So it's also important to note that family context holds information about how addiction develop or maintained and what can positively or negatively influence the treatment of the disorder. So effects of substance use disorders on families may include emotional burden. So example of that could be family members may feel angry, may feel frustrated, anxiety, fear, worry, depression. They may feel shame and guilt or embarrassment. And sometimes clients that I have worked with have expressed this anticipatory grief or loss. There is also an economic burden, money spent on substances, loss of job or reliance or public assistance may cause economic burden on the family. Relationship distress too, high rates of tension and conflict related to SUD and the problems it causes in the family. Then we have family instability that could happen, so potential result from the abuse or violence. Example of it, that could be resulting in family breakup because of separation or divorce. So I'll pass it on to Jessie, who would talk more about the need and treatment. If I can get it working, there we go.
So, as we have discussed, the nature of addiction is all encompassing in its effect on the individual and on the individual's support systems. And thus, the need in treatment must match this effect and address all of the areas and the other individuals in a person's life affected by addiction. So, the treatment is not only for the person, but for those in the person's life. That need is there. We see the cyclical effect that perpetuates throughout this person, and the treatment process needs to provide the right level of support and education for that individual and the social support and family support networks that are assisting them in this healing process.
All right, and so Jessie's going to move us into talking about the use of education and treatment.
As we have discussed this research team, we recognize the need for addiction treatment to match the way addiction affects an individual's life and permeates their social support and their family support networks, and that the same treatment needs to be provided to the family system for the individual to ultimately heal. Our literature review for this present study also found some other research articles and additional information that matched this view. We found numerous pieces of literature in this review as we were preparing for this study that shows the importance of an education of the individual for their addiction. This kind of likened it to the same process that one may receive when they go to the doctor or the hospital for a sprained ankle or perhaps the flu. That the doctor or the healthcare professional provided them some patient education, a handout, some information about the diagnosis, the reason this happened, maybe how it happened, and then the corresponding treatment and healing process to match this diagnosis. All of this is provided in this patient education. One article discusses that addiction needs to be treated in a similar way. Other research has shown the effect and the importance of this education, discussing how psychoeducation about addiction for the individual, not especially about its neurobiological roots and the disease of the mind that this addiction happens to play out with, is crucial in reducing future hospitalizations, overall increasing treatment compliance, and overall healing from this disease.
All right. So going into lack of research, Merck and Oz 2016 suggests that the experiences of family members of those with substance use disorders are largely neglected in the research. So that's really important to highlight because it's evident and understandable so that research and scholarship may do focus on individuals solely on addiction. However, the research is limited in addressing best practices of engaging and helping families and significant others. Merck and al. Also found that there's less than half a family study defined addiction as a disease, while most family members believed addiction should be described as a symptom of other problems. So, however, we found no studies in our literature. So there's a big dearth in our literature, more dearth in the research that's highlighting the use of this neurobiological psychoeducation in treatment, specifically for family members of the client in treatment. So we'll jump into psychoeducation and treatment, why it's important. So it is very valuable resources. I think we can all relate as clinicians, practitioners, that we use psychoeducation to help benefit our clients to have an understanding on what is happening when they're in the therapeutic space, when they're sharing their concerns. It's a valuable resource for those seeking treatment for substance abuse disorders. It provides a way to understand the complex science of addiction in simple terms. Psychoeducation provides practical skills, coping strategies that help people in recovery diffuse dangerous situations and avoid a potential relapse. Psychoeducation can reduce the number of future hospitalization, impact of symptom from the disease, and increase in overall treatment compliance for those with SUD. Family members are also encouraged to participate in psychoeducation classes. This is really helpful for them to understand the condition and support their loved ones go through the recovery process, so without losing themselves or overexerting themselves in the process. Now I'm passing it over to Jessie. She'll talk more about family support. If I can get the video playing. I'm sorry, everyone. Let's see. There we go.
So as we have shown through this discussion of the literature review we did for this present study, it is important for the family to receive a healing process and similar supports while the individual is healing from an addiction disease. Just as the disease causes consequences and challenges in an individual's life, it causes additional stress on the family support and social support network. However, what was less prevalent in this present literature review and not really seen out there was if this same level of education, patient education, specifically about this neurobiological root of this disease, was being provided to family members in the treatment process and for those who are social supports for the individual. Despite the evidence that the family system needs treatment as well, given the addiction permeates multiple levels of an individual's life. And this is what leads us to this present research study.
All right, thank you, Damaris, and thank you, Jessie. And no problems on that video. I don't even know how to put the video into the slide, so I think that's impressive that that was in there. But we wanted to make sure Jessie's voice was heard. She's done an equal amount of work with all of us on this team, and but I wanted to just kind of introduce us more to sort of getting into the methodology of the study too, and some of the issues that we faced The first thing we had to think about was, okay, here's what we're interested in. We're interested in neurobiology of addiction, first and foremost. We know that when, and the evidence is really clear in the literature, that when clients who are getting treated for addictions get educated about the neurobiological nature of addiction, that they have better clinical outcomes. That's a great start, right? But then what we wanted to know was what benefit would this have if this was being applied to the family members of the folks that are around that client, and how beneficial would, what kind of family member outcomes would we see? And so as Damaris pointed out and Jessie pointed out, we didn't really find anything in the research that talked about working with families. Well, we found things about working with families, but we didn't find anything specifically about educating family members about the neurobiology of this disorder. So we felt like, well, this is an open area that needs some examination. But then we had to decide, well, who do we even ask about this? What family counselors are out there doing this work? We started really broadly. It's a national survey. We surveyed family counselors, and so the first problem we had was identifying who does this work, because there is no professional association out there for family counselors who work in addictions treatment centers. There's family counselor associations, but looking at and trying to get specific, like how can we find out what counselors are doing this work? We started with a SAMHSA database of treatment centers across the country. I had two GAs who did really hard work for about 2 months, really calling every single one of those treatment programs in the country, over 500 of them, and asking to speak with the family counselors or get the contact information for the family counselors that did this work. And we got quite a database from that. We sent the survey to them, and we also utilized the North Carolina Substance Abuse Practice Board's mailing list, because we knew that folks that were doing that were licensed in this area, this specialty area of addictions, that there's a good chance that some of those folks were working with the families too. So we had a pretty good database there, and Dr. Warren can talk a little bit about the return on that and what that meant for us. It was significant, so we feel good about moving forward with the data. So really the difficulties were identifying the entry point for who would be able to give us some information about this. And we were also wondering, like, how comfortable are the family counselors that are doing this work? How comfortable are they talking about neurobiological concepts? It doesn't, I've encountered different reactions from people that do this work. I think most people understand that there's neurobiological components to the process of addiction, but maybe that they haven't really conceptualized how to understand that, but maybe even more importantly, how to communicate those concepts in a way that makes sense to clients and to their families. In other words, what is the bottom line here, right? What is the bottom line for why you need to understand what's going on in your brain, and how does that change your recovery path? And so we were interested in whether people were doing it and whether they felt confident in doing it. And we asked a lot of other things that we were interested in too, which we'll talk about more in just a second. So I want to kind of move on and talk about the research questions. I'm going to turn it over to Dr. Warren. He can kind of take us through where we started with that, and then a little bit about the methodology.
Yes, sure. Thanks, Dr. Schwarze. My name is Jeff Warren. I'm a counselor educator, associate professor here at North Carolina Central University, and I also serve as the associate dean here in the School of Education. So just picking back up from where Mark left off there, and Damaris and Jessie, when we take a look at the literature, there was a dearth of information as it related to this topic. So as a result, these are some of the research questions that emerged. So we were interested in exploring the perceived efficacy of clinicians providing family-based substance use counseling. We also were looking at or wanted to determine if there were any significant correlations between professional factors, i.e. Graduate degree, licensure level, licensure, whether or not the program that they graduated from was accredited, and perceived efficacy. And then lastly, we're interested in exploring the frequency of the use of modes of services and interventions. So moving on and taking a look at the next slide here, we see the methodology. So I'll just take a look at these items here. As far as the sample that we used, it was a national sample. However, the majority of participants were from the state of North Carolina. We had a total of 80 who completed 100% of the survey. Of those participants, 74% of them were indicated being white, 15% African American, and then 4% American Indian. The majority of the participants also reported being female. In terms of the actual survey, we did create a measure to determine perceived efficacy for this sample here. And we did use guidelines provided by Bandura in a chapter that he wrote on developing self-efficacy measures back in 2005. Some of the examples of the items that we used on the measure include understanding and explaining the basic process of the neurobiology of addiction, or understanding and explaining the basic process of the neurobiology of addiction. So for these items, along with the others, participants were asked to rate their degree of confidence in implementing the following counseling intervention or modality to family members of clients with substance use disorders by using a scale of 0. That meant I am completely not confident in using this intervention or modality, and a 10, which means I am extremely confident in using this intervention or modality. So participants could indicate their perceived efficacy on a sliding scale of 0 to 10, which also included tenths and hundredths in their rating. We did complete an initial analysis on the measure, and alpha coefficient for the measure was 0.90. So that essentially indicates strong internal consistency. And so again, as we go through here, I just want to note that these are all preliminary results at this point. Also, in terms of the survey, going back to take a look at the frequency of use, and then also demographic questionnaire. So we included licensure questions, degree, geographic location, and such. In terms of the frequency of use and that part of the survey, those were essentially aligned with the items that were on the perceived efficacy questionnaire. When we take a look at the data analysis here, I'll quickly highlight a few points here. This is an analysis of variance. Hierarchical regression analysis. And if you see, I'll scroll down, well, I'll move down here. If you take a look at step 1 here, so when we conduct a hierarchical regression analysis, we embed factors at various steps. And so step 1 here, essentially what I plugged in was demographic variables, specifically gender and race. And so we had to create what we call dummy variables here, indicating either 0 and 1 for each one of those variables. So the important thing to note here is that if you look over in the far right-hand column where it says significance, that is a 2.93. That's not significant. Taking a look on down, you can see the exact same thing there for step 2. There was no significance when we added degree. And whether or not the degree was from an accredited university. Again, no significance. For step 3, we actually added an addictions license in that step, and you can see that there was significance there. So as it relates to self-efficacy, those with who possess an addictions license had greater levels of perceived self-efficacy as it relates to providing substance use counseling. And then in step 4 there, we added whether or not the clinician identified as a family counselor or not. And that is significant, but it's actually that variable is not significant because the fact that the clinicians had the addictions license is what makes that step significant. So we'll take a little bit further of a look at this when we move to the next slide. So again, this is a summary of the model here, and you can see a lot of what I just shared here. We have the steps over to the left-hand column there, steps 1, 2, 3, and 4. And again, I'll just highlight step 3, the addition of the addictions license was quite significant there, 0.003. And again, that indicates that there was a significant relationship between the addictions license and perceived self-efficacy, a positive relationship there. Those other variables that I referenced earlier, degree, whether it was accredited or not, those were not significant and did not play into the model here. Well, I do want to point out, if you take a look kind of in the middle of that table, you can see R squared change, and you see 0.10 for step 3 there. So essentially what that means is that the addition of the addictions license for these participants accounted for approximately 10% of the variance explained in their level of self-efficacy. So that's pretty significant. Again, so that's the key variable at this point in our analyses that we're trying to hone in on. I do think that because of the variables and the other factors that Mark suggested earlier that kind of played into the collection of this data, that we do want to continue to kind of tease out our data a bit more as it relates to accredited programs versus non, level of degree and such. So if we take a look at the next slide here, now this table here provides us with an overview of the frequency of use. And so you can see each color represents a different type of session. So we have blue indicates individual family counseling. We have the gray, which indicates couples and marriage counseling sessions. The orange indicates group family counseling sessions. And then you have the kind of goldenrod indicates multi-day and weekend counseling services. And so across the bottom here, you can see various services or interventions that were used. And we have 12-step, for example, going across the bottom. 12-step spirituality is the second one there. And we move on across, and later on you can see that there's reference to providing neurobiology or explaining the neurobiology of addiction and so forth. I think what's important to note here as we take a look at that, the vertical axis there going 0 to 10 in terms of time spent, that there's a lot of similarity across the various modes of service and the frequency of use of the various interventions. And so regardless of whether it's individual family counseling, couples, marriage, group family, or multi-day weekend, with the exception of the multi-day weekend, which could likely be accounted for the length of time that those sessions occur. There's a greater amount of time. In other words, that may suggest that by default, there would be a greater frequency provided by the clinician in each one of these interventions. Again, when you take a look at the vertical axis, most of them are around 5, 6, and 7, which indicates that they're frequently used. So there's none of them that are really used excessively, nor none that are used very sparingly. But I think it's important to consider that if the clinicians are using each of these at a relatively frequent rate, then are any of these interventions being used with quality? So we have the quantity there, where they're all being used, but to what degree? What's the quality of which they're being used? So that kind of takes us, I think, to the next slide, which is implications. And we have a few, I believe, as we go through the continue to analyze the data, I expect that there will be additional implications that may emerge, and you may have some as well as we are going through this. So the first one here, placement of addiction certified counseling in counseling and treatment programs. So here I think we're referencing if individual clinicians with addictions degrees have greater levels of perceived efficacy in providing these services, then is there a sweet spot, for example, of where these individuals should be placed? If we're making the assumption that efficacy leads to effectiveness, and there's a lot of research that does suggest that is the case, and I referenced that down below. Specifically, is there an opportunity to be intentional about who is providing which services at what time to the family, so they, as Dr. Schwarze mentioned earlier, so they can best provide information and explain the neurobiology of addiction to the families. So something to consider there. Another possible implication is CEU requirements for non-addiction certified clinicians. So oftentimes licensure comes with the requirement to complete X number of CEUs, obtain a certain number of clinical experience. So for those that do not actually have an addictions license, could there be some type of a requirement for CEUs or experience that kind of replicates or mirrors what the addictions clinicians, licensed addictions clinicians are receiving or experiencing? Again, when we take a look at educational requirements for counselors in training, again, perhaps there should be a review of the coursework and practicum internship experiences of those counselors in training that are pursuing non-addiction pathways. Again, I referenced the quantity versus quality of interventions. And so I think this is an area where we can certainly do a bit more research to better understand the quality versus the quantity across the various modes. So if there's one or two interventions that can be highly effective, then we want to focus on those. We want the addictions counselors to focus on those with the families, as opposed to just kind of throwing everything, including the kitchen sink, at the families. I referenced efficacy versus effectiveness. Again, we did not really drill down to determine how effective these addictions counselors are, but the key takeaway is that there is a lot of research that suggests high levels of efficacy leads to effectiveness. And so when we look at these addictions counselors specifically, or family counselors who hold the addictions license rather, there's the data does suggest that those clinicians do have higher levels of perceived efficacy as it relates to providing these counseling services to families. And the bottom line is, at this point, because there is such little research that has emerged in this area, I think this is kind of cutting edge and is really exciting. But there's obviously much more research that's needed. So this research, I think it provides some insight, but it also leads to a lot of follow-up questions. So, yeah. And then if others have additional insights here, feel free to jump in.
Yeah, thank you, Dr. Warren. These were really complex, complex kind of analyses that Dr. Warren's running for us, and we really appreciate that expertise that he has in that area. And we're still kind of combing through that data at this point in time, and there's going to still be a lot of that work. We're going to hoping to have the data analysis complete and start writing this up and getting it out for review somewhere by the summer for sure. And we're excited about where this is going, because it's meeting a need that is not there presently in the research. Is what are we doing to be able to help family counselors be able to provide these services to families who have someone in their family that has a substance use disorder. And part of that is that we believe that these neurobiological approaches in education and psychoeducation can be a real key piece to that. And we know it works for the clients. We know when they hear about this being a brain disorder, when they hear about, what created the behaviors in them, what created the cravings in them, those neurobiological processes that, create those urges and the loss of control. And it's not about willpower and your own sort of moral failings, then it really reduces the shame and the guilt in the clients. Now, what I'm interested in as we think about, and Jeff talked about sort of, we need more research and where are we going with this? The team's already thinking about those things. We're thinking about, future implications, future research projects that we can do around this. And we're definitely interested in talking to family members who are going through these educational programs, these family days, and what was it about those education programs or those interventions that were given to you as a result of someone being in treatment. How were they helpful? What were the topics that were helpful? What were things that you thought were really important? Because I do think that neurobiological education for the family members can reduce their anger, their misunderstanding, their frustration with their family member. And if we can reduce that, then we might be able to increase empathy. These are all just sort of thoughts. This is where future research could go for us. Is there a way would potentially being educated about neurobiology increase empathy, and would it increase and decrease frustration and anger? And think about the possibilities for the client being able to be in that type of support system that has that. We're just a few minutes out from being able to be finished. We had one question Keith asked about clients that were doing medication assisted treatment, getting Suboxone or Subutex and who are in recovery, but they're resistant to getting into 12-step programs for additional support. Now, that's not really that wasn't really the focus of our study or what we were talking about here specifically, but I do have just a couple of quick thoughts about that. Is, medication assisted treatment generally, if you look at it across the board, and it really is dependent upon what agency is doing it and how they're doing it. But I think that the research has kind of revealed that in medication assisted treatment, that the counseling component to that has been largely ignored. And so one of the things that I think we will have to do is figure out a way in medication assisted treatment. And that's a really great place, by the way, to talk about neurobiology, because they're taking medications that are changing the neurobiology, that are mitigating the symptoms. And so that's a place for clients to be educated about that. And, since generally families aren't necessarily connected into those types of programs, having some kind of virtual option for those families to be able to go through and learn about. 12-step programs are fine, and I think they have a place, but the research around those programs haven't shown a lot of great efficacy around client outcomes. And so I would say that what I would want you to do is, instead of trying to get them into 12-step meetings, get them into professional counseling with a professional, and maybe in some kind of IOP or in some kind of counseling group.